Hi, I'm Shelley Wood, the managing editor at TCTMD. This is On Record, a regular program looking at hot topics in interventional cardiology and beyond. My guests here today are Dr. Judith Hochman, Dr. Sripal, Bangalore, and if you might have guessed, we're going to be talking about ischemia. Thank you both for making time in your busy schedules to come on the program.
Pleasure. Thank you for having me.
Okay. It has been several weeks now, months even, since ischemia came out, and I'm really curious to hear from both of you what your colleagues are saying. Dr. Hochman, I know you're not on Twitter, so you're not listening to that rabble, but what kind of reaction are you getting? How are people taking some of these results into their practice?
Well, it's been overwhelmingly positive, the feedback. Okay. It started at the American Heart Association meeting. The panel was incredibly complimentary.
Yeah, it was a great discussion at AHA, I will say that.
Saying it will be guideline and practice changing. People stopped me in the halls at the AHA, congratulated me. I got tons of emails. And back at NYU, it's been the same thing. And I spoke at the New York Cardiovascular Symposium last week, the American College of Cardiology, and the same thing. A lot of congratulations.
So I'm sure I've heard across the board that people are so impressed with how the trial's done. So the congratulations don't surprise me. But are you hearing from people that they will be implementing changes into their practice as a result of this? Especially I'm thinking with the ischemia CKD findings, because of course there was no benefit, even for the angina, the quality of life. What do you think people are doing?
Yeah, I think as of now, at least people know that there is an answer. They've been waiting for a long time for a big clinical trial, and now we have an answer to that. And people, at least the ones that I've been speaking to, they're waiting to hear, look at the full manuscripts, make sure
I hear that a lot.
Where this actually fits into their practice. But, people are paying attention to it, and there is no benefit, and they're looking at that.
Because this was a very understudied group, the CKD group in particular, so it's new data where they didn't.
It's new data, there is no randomized trial in this space. The previous one was a 26-patient randomized trial back in the 90s, and that's all the evidence we have.
Okay. In many ways, though, the spotlight has been on those main results. And one thing that I've heard people say, surprisingly, I think, is that they already knew this answer, that they haven't got new information from this. What do you say to that?
Wow. That's what I say to that. We went in with equipoise. We had data that there was equipoise out there. The sites had equipoise. But there were a lot of people that thought they knew the answer, that invasive was superior. Right. So to now say they know the answer, it's, the results are a little complex, but for anybody to say they knew the answer, I just think is disingenuous.
Yeah. I think partly I'm interpreting it as we already knew that an invasive strategy would make people feel better. And so related to that, I'm hearing quite a few interventional cardiologists, for the most part, saying this won't change my practice. And how do you respond to that?
Well, so I would say we had no data before this that PCI would have a durable effect on quality of life.
True. Okay.
Courage showed an early benefit and no durable effect. Barry 2D showed an early benefit for PCI, which was not durable. The CABG benefit was durable. And then, of course, Orbita was very complex in terms of the initial spin that it wasn't any better than sham in terms of various endpoints. So I think this is important data that the PCI chosen mode of revascularization and the CABG both had durable benefits on angina. Yeah. And the degree of the benefit is very important to be able to tell patients.
Yeah. So I'm glad you raised, sorry, were you going to jump in on that too?
Yeah, I would say in terms of the things that will change for interventional cardiology, there was always, if you see a severe ischemia, people used to think of these patients as MI or ACS equivalents.
Really?
Send them to the cath lab immediately.
Yeah.
At least this trial will say you don't have to rush into that. I think that's the first thing. To me, that comes to my mind.
It's not an emergency.
It's not an emergency. The practice across the US has been that if you have a patient with severe ischemia, they go to the cath lab immediately.
Yeah.
So at least that one, I think we can pause and say, shared decision making.
Okay, I'm going to come back to that, but the one thing you raised Orbita, because one of the other things that people have said about this trial is that it wasn't sham controlled, and if the benefit was all in terms of placebo, we actually talked about this at AHA, you know, is there any possibility that people knew that they were quote unquote fixed and that's why they feel better? Are you at all worried? I mean, you didn't see any benefit in terms of quality of life in the CKD trial, but is it possible that because this wasn't sham controlled that that has any effect here?
Yeah, so we believe that based on the durability of the results, at 3 to 4 years, people are not going to
Placebo
go
doesn't
back
work
and
that
say,
long.
gee, you know, 3 or 4 years ago I had this procedure, therefore I don't have angina. You know?
Okay.
And as John Spertus has pointed out, when you look at the analysis in Orbita, that is the proportion of patients that were angina-free,
Right.
their difference was the same as the difference we saw.
Yeah, okay.
And just to add to that, I mean, if it was a placebo or a sham effect, we should have seen that same thing in CKD trial.
Right, okay.
We didn't see that.
Fair
So
point.
I think whatever we are seeing is a real effect. In the CKD patients, we don't see a large benefit. In the main trial, we do see a benefit. So if it was
Okay.
sham, we shouldn't have seen it.
Okay.
We should have seen the same effect in both trials.
So when I hear people say, "Oh, you know, we knew this already. We knew that there would be that quality of life would be improved," I don't think I'll change my practice, is what I have seen on Twitter, for example. And yet, one of the really striking things that came out of the presentation was, and you made this point, was that we've heard a lot about $100 million in taxpayer dollars were spent on this. But you said that actually the cost savings could be expected to be $500 million per year, if I've got those numbers right.
More than $500 million per year.
More than $500 million.
Right. $570 million is a conservative estimate just based on PCI, not
Okay.
cabbage savings.
Now, so the point I wanted to clarify, is that going to be all of the elective procedures that will not be done? Because I'm having trouble understanding how someone who doesn't have symptoms would end up not being treated, who was already being treated before, if you know what I'm saying.
Well, there are data that it was for elective procedures, and it was
Okay.
only for those that were asymptomatic before
Okay.
the procedure. There are people that get a stress test looking for disease, or get a CCTA right now looking for disease, and then when they find disease, go for a stent
Okay.
with no symptoms. That happens.
So
And we
that-
made the calculations based on the data, based on asymptomatic patients going for PCI. There's another issue. You know, 90% of the patients in the trial had angina at some point in the past.
Right.
Within the past month, the data that John Spertus presented for baseline, how many had no angina, which was something like 36%, that was only in the last month. So it means that medication therapy used to make them angina-free applied to those that didn't have a benefit because they were angina-free at
Okay.
baseline, not ever.
Yeah. So to those who say that taxpayers' dollars were squandered in some way on this trial, you would disagree, presumably. Whether those cost
Big
savings can
savings.
be made, I suppose, depends on how these results are interpreted. I did want to go back to the point you raised about the sort of severe ischemia, and I'll let you jump in.
Yeah.
But if you are having, we now know severe ischemia doesn't necessarily translate into, well, we know revascularization was of no benefit. At what point then does this sort of train towards, we always heard with the COURAGE trial that the train has left the station and we need to have these conversations with patients earlier. When do these conversations with patients, where they're given the information from ischemia, it's explained to them the risks and benefits, where should those conversations happen such that those unnecessary elective procedures don't happen?
Yeah, I think after COURAGE and all of the other trials, the unmet need was, is there a high-risk group of patients? What about moderate to severe ischemia? I mean, is that itself a marker for worse outcomes? I mean, now we know from ischemia, not really. I mean, the treatment may not change if you're asymptomatic. To me, the workup of asymptomatic patients needs to change upfront. When patients are being seen by cardiologists. I mean, if they are asymptomatic, why do a stress test?
Right.
I mean, because
that's where the referrals are happening. That's a positive stress test, and then it comes to
trickles down.
Yeah. Okay.
So I would say two things to that. One is to go back to a point that Sripal made earlier, which is people say they already knew. They didn't know that if you had severe ischemia on a stress test, you were going to have such a low event rate when treated well with medical therapy. They didn't know that. Because there are a lot of protocols, as Sripal said, where they have to go straight to the cath lab after a very positive test. I think, and a lot of people are discussing this, and we discussed this at the symposium on Friday, So what is the right strategy now? And the bottom line is, if someone has angina, and you know that it's angina, you have a discussion with them. They're on medical therapy, let's say, or you start medical therapy.
Right.
You say, these are the data for an invasive versus conservative strategy. This is what you can expect. And you engage in shared decision making.
Right.
And if they say, in fact, they want an invasive strategy based on the data that you're sharing with them, you go straight to the cath lab.
Okay.
I don't think you need a stress test. I don't think you need a CCTA.
Okay.
If,
Cost
on the
savings
other
there, too.
hand, they say, I'm fine with this level of angina, I don't want an invasive strategy, then you need a CCTA to rule out left main,
Yeah.
and in fact to confirm that they have obstructive disease,
Right.
that it's not just microvascular angina.
Yeah. The CT folks are, of course, very interested in those findings, even though it wasn't a sort of part of the experiment itself. So that's a whole other discussion we could have perhaps at a future date. But I did want to just go my final question is with these pesky periprocedural MIs versus the spontaneous ones later on. I know you're looking for extended funding for ischemia to be able to follow patients longer term. If you had to, put some money on it right now, do you think longer term follow-up will show that those mortality curves diverge with more spontaneous MI? Or are you just not going to predict that on camera right now?
Well, let Sripal take that, and then I'm going to weigh in. I may not predict, but I'll weigh in anyway.
I think it's a tough question. I mean, the question is, will the overall mortality change? Overall rates of MIs
Right.
change? Maybe I can kind of predict that potentially the curves may continue to separate.
Right.
But mortality, I'm not sure. And I think that's
Okay.
one of the reasons we are planning to, apply for funding.
more funding. Okay, I think that's fair. And then I guess...
I think it's important for us to settle the question with long-term follow-up.
Absolutely.
Because the incremental investment is pretty small, and it's one missing piece
Sure.
to a lot of information we provided. It's perplexing to me that, spontaneous MI, we know from a lot of data sets, has a prognostic implication for increasing all-cause mortality.
Sure.
So it's perplexing that for all-cause mortality, there's just no signal
Yeah, quite a
of
disconnect.
divergence. And I can't remember a trial, and I've asked a number of clinical trialists, where they've seen superimposed all-cause mortality curves for 5 years that then diverge late. There's no precedence.
Okay.
So we'd have to ask, what is it about perhaps events in the invasive strategy that are counteracting that? The excess heart failure, although it was numerically very low.
Small.
The periprocedural MIs.
Okay.
And there's one other, which I think I mentioned in response to a question at the AHA, the issue of potential ascertainment bias.
Okay.
That people came back with chest pain late on, the physician didn't hospitalize those in the invasive strategy because they thought they're
We
fixed.
fixed it.
They did hospitalize them in the conservative strategy, so they diagnosed a spontaneous MI.
Okay.
I mean, we've got to try to sort this out. We're not going to be able to sort it out with certainty. I think we need long-term
With more time,
follow-up.
yeah. And I understand that the completeness of revascularization, that's also an interesting question, but that one is being addressed at ACC. Will we get some numbers?
We hope.
Okay.
We've submitted for
Oh, they're going
that to be presented.
Yeah,
We'll
I have
see.
no doubts. A last question then. In this space, what's the next trial? Ischemia Grid of Courage. For you, what is the unanswered question that you'd like to chase down next? Doesn't need to be you that does it, but you'd like answered if possible.
That's a tough one. I think in terms of...
You have a
right.
trial planned.
So,
It's not so tough.
So I think, there are other things in the space. For example, if you have patients with low EF, we know from STITCH that revascularization with cabbage is beneficial. Right. The question is, we all do it. Is PCI beneficial in those patients? So PCI cabbage in patients with ischemic cardiomyopathy, I would think, is one of the pressing questions that needs to be answered.
Okay.
What about beta blockers? So we plan ischemia 3. We have a planning grant for low EF PCI versus cabbage. Stu Katz is the PI of the planning grant,
Okay.
to try to assess the feasibility and what the specific design features would be. And beta
Beta
blockers.
blockers.
Yeah, and the extension of all of these is, we talk about OMT, guideline-directed
Yeah.
therapy. The question is, what is it? I mean,
True.
and
I think I met you over beta
Beta
blockers.
blocker.
Stories back in the
Likely.
day. Yeah.
Yeah, so we're trying to address that question. So
Okay,
is
that's
beta
a hot button
blocker
one.
in the modern era of everything else we do?
Statins and everything
Statins,
else.
is it still beneficial?
Okay, great. Dr. Hochman?
Those
Just
are the ones, and
Those
there's
are-
one more.
Okay.
So we have cardiogenic shock.
Yes.
We've really reached a plateau
That easy subject to
in
study.
terms of those who undergo revascularization. There's been no change in mortality from when we did the shock trial with PCI, despite
Right.
the advanced techniques we have, compared to, for example, culprit shock, culprit-only vessel.
Right.
No difference. Stu Katz and I wrote an editorial in the New England Journal. We cited that
I remember.
specific data. So the question is, for multi-vessel disease and cardiogenic shock, what about PCI versus cabbage?
Oh, wow. Okay.
We have been planning and accumulating feasibility data. We have a survey out there. You could search online and fill out the survey if you haven't already.
I won't
So that's
taint the numbers
the
by doing that, but okay.
Hopper.
And does that include some sort of LV support?
It's whatever you choose.
Okay, fascinating. So much more work for both of you and much more work for me down the road, I'm sure. I know how busy you both are, so thank you so much for taking time out of your busy schedules to talk about this with me today.
Thank you.
Thank you.
And thank you for watching On Record.